there's a real sense of urgency to move something very quickly, which leads them to this repeal-only option, which is, I think, front and center. And I got to admit that I think both Speaker Ryan and the Majority Leader McConnell have both signaled that they basically want to do this. Now, when that happens, normally something happens, right? You got the two leaders of both houses with the votes, presumably, to move something, makes you think, it might happen. So what does this entail? Basically entails passing very, very quickly in the early days of January a new budget plan in Congress. It would be a status quo budget. It wouldn't have really anything in it. It would just be current law. They wouldn't change any taxes or any spending or anything. They would just do one thing, which is to say, pass a bill subsequent to this budget resolution that rolls back some key provisions of the ACA, the Affordable Care Act. And if they do that through the budget process, they potentially could pass it with a simple majority vote in the Senate, which is the key, right? So you have 52 Republicans at the moment in the Senate going in January and 48 Democrats. So if you can hold 51 of your 52 senators together around something, you can pass something under this kind of procedure without any Democratic support. And they will get no Democratic votes for a clean repeal bill, so they'd have to do this strictly with Republican votes. Now, so far so good from their perspective. I think the obvious point, and I'm sure this was discussed this morning already, which is, well, wait a second, what are they repealing, and what are the consequences of it? Well, they talked about doing this with a 2 or 3 year delay. So they would not change anything immediately, set that aside for a moment, but roll back some of the major provisions of it effective in 2019 or 2020. Date to be determined. The idea being, from their perspective, they could say to the public, look, we've put an end point now on this law, and we will work over the coming period to replace it with something better. I think that's the general political framing they want to put on this. Myself and many other people have said this will not work, that they won't be able to do it with that kind of political framing because of the upheaval that it's likely to set in motion in the insurance marketplace, that the amount of tumult will be, maybe not be catastrophic, but it would be pretty high, and so high that the blowback on themselves would be, sufficient that they would end up bringing more trouble on themselves than maybe they're anticipating. But anyway, that's still the leading option, I must say. They haven't gotten off of it yet. And so I would say that absent something changing, they may proceed down this road. A very key question, which I wrote down here at the bottom, is would they couple the rollback of these major provisions with immediate rollback of the penalties associated with the individual participation requirement, the individual mandate? So they might say, well, we'll sunset the exchanges and the subsidies and the structure associated with the exchanges in 2 or 3 years, but the mandate to participate in them will get rid of effective immediately, which means that there would probably be some exits out of the individual insurance market. If someone didn't have to pay the premiums anymore without any penalty, yeah, you'd have some group of people who would drop out, at which point the losses for the insurers would be even higher than they probably already are anticipating. So the level of instability would go up. I think the Republicans would invite that on themselves and end up with a fair amount of trouble associated with it. So what do a lot of people have said, well, there are no alternatives to the ACA, and then, you think, well, what are the folks who are coming into power, what are they looking at? Because much of the country has heard, hey, there is no alternative to the ACA. Well, I think they would probably be drawing from these 4 rough, outlines, the fourth one being the most rough. But the Speaker of the House and the key committee chairman released a plan. It was a blueprint. It was 40 pages or so, something like that they called a Better Way healthcare plan, which they also did a Better Way health tax plan, by the way, and a few others. But they did a healthcare plan that they released last June, and it's not everything, but you can get a pretty good sense of what they would do in it. Okay, I'll tell you about that in a second. The new incoming, perhaps, Secretary of HHS released his own bill. He also participated, by the way, in producing a Better Way, and so the price plan plus a Better Way, they're very similar. And then on the Senate side, you have, also in conjunction with Congressman Upton, you had Senator Hatch working with Senator Burr and Congressman Upton on what they called the Patient Care Act. It also structurally is not that different from these other two plans. And then there's the fourth wild card, which is the various things that appeared every once in a while with who knows what approval on the Trump campaign website, okay? Or any knowledge, or who wrote it, and how much awareness that it was showing up there was not really ever clear. So let's talk about the first three, and then we'll go to the fourth. The first three, I mean, things that recognize about it are that it has some similarities to the 2009-2010 ACA, okay? So what does it do? It recognizes, number one, the same thing the people that put together the ACA recognized, which is that it's pretty hard to move away from employer-based health care in the United States, okay? Once you kind of walk up to it, Republicans have talked for years and, of saying, it really would make more sense if we got away from this big tax preference for employer-based health care. I think when you walk up to it politically, most people end up walking away from it, realizing there's 160 million people in the system, and when you poll them, it's like your congressman. Everybody hates the system, but they more or less like their own health insurance plan. It's better than the alternative, okay? And so most people that are in employer-based health care would rather not have that particular boat rocked too much. And that's true of these three plans. All three of them, in a sense, retain the employer-based health insurance system and put an upper limit, substituting for the Cadillac tax, on the tax preference for employer-paid health care. But it's very high, and so most plans would be unaffected. Maybe the top 10 percentile, maybe the top 20 percentile would be affected by an upper limit on the tax preference as both a cost constraint and a revenue raiser. So all three of those plans have that in common. And then they say, for people that are outside of employer-based health care, we want to give a refundable tax credit. Sounds a little bit like premium credits, okay? Now, why do they do that? Well, they do it for the same reason people who drafted the ACA did it, which is that health insurance and health care in the United States has become so expensive that relative to an income of $30,000, it's going to be very difficult to imagine a system working that people get into some even basic level of insurance without some additional financial support. And it's only a matter of fairness, frankly, that it's roughly comparable, at least, to the tax preference that's available to people through the employer system. And so as a matter of rough justice, there's a tax credit that's refundable in each of these three plans. Now, they do them a little slightly differently and so on. But that's sort of the beginning point. Now, I would say the following about this, which is, I think, the crucial point for the future of American health care and whether or not we can ever get to some stability in a bipartisan way around health care. This is something I think the Democrats should have seized on more and try to draw Republicans in on, which is that the Republicans, in effect, concede through these 2 points around employer-based health care and refundable tax credit that basically everybody in the United States should have health insurance, right? Either you're in the employer-based system, or you're in Medicaid or Medicaid, or if you're not in one of those three, you get a refundable tax credit that can be used for only one purpose, to get health insurance. So by definition, the idea would be everybody in the United States should have at least some level of health insurance protection. Now, from there, I think a conversation could occur, but there's so much noise around many aspects that it hadn't happened yet. But that, I think, is an important point, okay? Now, the tax credits are not nearly enough compared to what people think is necessary relative to the premium credits under the ACA, so there'll be a big fight about that. There'll be a big fight about what's required to be in the benefit package that is purchased by a tax credit. Big fight about who gets to regulate that and make decisions about what's in the insurance plan and so on. But at least on a structural sense, I think there would be more consensus amongst folks if they sort of talked about that commonality and maybe the basis for perhaps reaching some compromises. Now, the wild card in this is the last bullet, the Trump campaign pronouncements, which are not similar to the first three. And so he's appointed now his Secretary of HHS, Price, who's really in line with these plans. But his own pronouncements have been to say, well, what we need is to allow more deregulation of insurance across state lines, a tax deduction for people outside the employer system, not a tax credit. There's a big difference between the two in terms of the incidence of the financial support that's available to folks. And a few other things that doesn't give you confidence that they necessarily have bought into some structural 1, 2, or 3 on the above, okay? So, this is not to say that there's a definitive answer here, but my sense is they're probably headed toward some version of 1, 2, or 3 above, because that's where the Congress is likely, the center of gravity in the Congress is. And to do what he pronounced on number 4 would be, once they got into a debate and analysis and CBO estimates of it and so on, would be viewed as inadequate by a lot of folks. And so I think they're going to be forced into numbers 1, 2, and 3, but maybe with a lot of broken glass along the way. It's hard to tell, okay? So something to keep your eye on. Okay, now let me step back from that and go to Mark's second point, which is what is this all about? Why are we doing any of this? What's informing any of the conversation around health policy in a normative sense? Because I think that really is what divides the country. There's just different sort of starting point differences that lead people in different directions. And these are some of the nuts and bolts of that. But I think to begin with, I would just say that someone were to kind of come up to the average median congressman, Republican congressman, and ask him what they don't like about the ACA, I think they probably would answer that it's too much government. And I think they're right about that. I agree with them about that point. The problem with the ACA is that it moved huge amounts of authority over every aspect of the health system from the states, employers, individuals, to the federal government. And so what we have here through the ACA is both on the insurance side and the delivery side, a massive shifting of power to the federal government. The bureaucracy at HHS can basically do anything it wants at this point. I mean, if you look at the authorities that are available to insurance regulation, the benefit package, the ability of insurers to set premiums, where and when they can market, how Medicare can influence the design and practice of how hospitals and physicians organize themselves. This doesn't even get to MACRA, which Republicans voted for, which also does the same thing. So I think there's a philosophical view, which I agree with basically, which is that this is too much. And the effect of it over a long period of time, not immediately, but over a long period of time, will be to push a lot of people into kind of healthcare arrangements they prefer not to be in, that are lower quality and actually less innovative than they need to be. Now, that's a point of view where you can never resolve it, right? Which is great for me. So you guys can all disagree, but I can say, this is my prediction, right? So I think that's essentially what this is about. It's about the level of government power over the health system and whether or not in the United States, a big, diverse, complicated country, that's going to work over, decades, especially understanding how our bureaucratic system works relative to other countries. So what does that then lead to? It leads to try to move to a system where there's much more decision making around where the federal government is actually still involved. I mean, people sometimes say, this crazy idea of a market-driven health system. President Obama tried to build a market-driven health system. He just did it in a way where there's a lot more federal power and government control than the folks who oppose it would like to see happen. So what are the elements of it? We already talked about some of them. One is to retain an employer-based health insurance system, put an upper limit on it so there's more, the incentives get lined up right at the upper end. Again, a refundable tax credit for people outside the employer system. I'll talk about continuous coverage protection in a minute on the next slide. Transition, that there should be some minimal disruption of folks. And then on Medicaid, try to move to a system where the decision making between the federal and the state government is more clear and defined. Right now you have a matching system where the federal government finances the program, and then because it's financing it, says, hey, we should be able to set a lot of terms and conditions around how it's used. The states then say, we like the federal money, especially its open-ended aspect to it, but we don't like these terms and conditions so much. So the result is that a system of bifurcated political accountability that I think is not operating as well as it should. And so the general approach under most of these plans would be to try to create more clarity about who's responsible for what, financing versus running the program. Medicare, this is something that Congressman Ryan, Speaker Ryan, has been pushing for a long time to try to move toward a system that is a little bit more consumer-oriented. Frankly, it would be like the exchanges for Medicare beneficiaries, right? So take the irony of that. And then fundamentally, something that moves people who are in higher deductible plans much more fulsomely into the ability to enroll in a health savings account and use that for the payment of services below their deductibles. Now, something I think is critical to this is this combination of people using their own resources, often through an HSA, to buy services below the deductible. I think philosophically this needs to be resolved amongst folks that are pushing for a more market-based approach to these things. There's sort of two strains of thought. There's one is, hey, let's move toward consumerism, which I obviously am somewhat sympathetic to. On the other hand, I also believe in integrated care, and I think people should be given the option, especially, of purchasing services in an organized system in some way that doesn't require just one-off fee-for-service payments for expensive conditions. And marrying those two is not easy to do, but I think it can be improved quite substantially by changing the rules around the use of HSAs and allow people to pay, in a sense, prepackaged sets of services from integrated care systems and not call it an insurance premium. As long as they have catastrophic insurance protection, allow the providers of the services to market and sell to folks Kaiser Permanente, think of, except this wouldn't be their HMO, this would just be direct services. Here's a package of access that you would get from us, and your insurance would kick in if you ever had a major event, but below that major event, here's how we organize your payment for access to integrated services. I think something like that needs to happen for this to work. Okay, so let's talk about this last element, and then I can get grilled by you folks for the last 30 minutes. So I think a big part of this and under consideration is this business of the individual mandate, and is it really feasible to think of something other than the individual mandate? And look, there's a lot of things in Washington are political labels, right? So I think they're going to have to move away from something called an individual mandate. On the other hand, I think Republicans would probably be in favor of personal responsibility. And the question is, how does one create the structure around which someone becomes personally responsible for enrolling in health insurance? And you could call it something called continuous coverage protection. Now, for those of you who know, I'm sure most in the room do know, the United States passed a law, Congress passed a law in 1996 that basically moved in this direction already, but it was very inadequate. Now, under HIPAA, that allowed and really did take out of the system a lot of the friction associated with movement between employer to employer health plans. And it did make it pretty seamless and protected most people. And before 1996, some people did fall through the cracks because of the friction that was between changing of insurance plans between different employers. So they did that, and then they tried to create, but they did it very poorly, a similar structure between the employer and the individual market, but it didn't work. And so what needs to be done, I think, if you get rid of the individual mandate and change some of these structures, you're going to have to recreate something similar to allow people to move from the employer system into the individual market and move between plans in the individual market in a similar non-friction way based on their health status. And they can do that so long as they are basically enrolled in health insurance with reasonable, some reasonable measure of what that entails. Obviously the penalty is if you drop out of the insurance system and then try to get back in later, you would be penalized. Now, one could create some structure around the penalty too. You could say, yes, you could be penalized up to this amount over this amount of time. If you're low income, only this amount. There could be structure around the penalty as well. But it has, look, I admit fully that a lot of this is around politics and how does the country absorb such a thing? And if it's sold to the country as the government is telling you you have to do something, it has a certain reaction. If it's told to you that you don't have to do anything, but there are consequences if you don't do something, and the consequence is this, it has a different feel to it. Now, that doesn't mean it's going to sell. It doesn't mean necessarily it'll work. But I think the politics of it are a little different. And so, we'll see. Each of the three plans that I was describing earlier rely on this approach. I think the other big element here is auto-enrollment, that it's a big, complicated country, as you're seeing with the ACA, and there are going to be some people, no matter what you do, who aren't going to take advantage of whatever is provided to have them enroll in health insurance. I think one of the mistakes of the ACA, and one that I think that if folks who are working on whatever is coming next should keep in mind, is I would put in a provision that puts people into health insurance first and asks them later, okay? And it's hard to do. You'll get a lot of pushback from people on the administrative end, but the mechanics are roughly straightforward. It's just execution of it is hard. You still require everybody to notify the Treasury whether they have health insurance or not. And that includes especially the employer-based system. And then anyone who's in the employer system or in Medicare and Medicaid or CHIP, they end up essentially becoming eligible for a refundable tax credit. And after year one, for years 2, 3, 4, and 5, a Treasury tape can be generated based on non-use of the eligible population. At which point you then, in an imperfect way, will start to reach out to the population that didn't use a tax credit, even though they were eligible for it, and didn't report being insured. And then you use that to sign them up for coverage that is equal to the credit. In other words, you don't have to pay anything. You buy as much insurance as you possibly can for the amount of the credit. And you put people into insurance, and then you allow them to opt out. Now, will this happen? I don't know, but a lot of people are talking about it. I think it's the right way to do this. It would take 3 or 4 years before the whole system really probably operationalized in a way that captured a huge number of people. But it's a way of making sure everybody in the country is close to enrollment in a catastrophic insurance plan. I think, frankly, you could attach a provision like that to the ACA, and you'd get near to 100% probably in 3 or 4 years. They didn't do it. I'm not sure exactly why, but there could be probably something I don't know. I think the other aspect is putting guaranteed money into the state high-risk pool system as well, federally, in some way that's known and won't be subject to the vicissitudes of a budget process. So some kind of guaranteed, X dollar stream that's going to subsidize people who will fall through the cracks, be uninsured, and need expensive medical care. And how are they handled in some kind of a system like that? They get penalized for a while, but if they're very low income and they can't afford the premiums, how do you make sure they get health care? You're going to have to rely on some kind of mechanism like this. So anyway, those are a few of the ideas that are under consideration. I think I've talked enough to kind of provoke a lot of people, so I think I'll stop there and then, happy to answer any questions.